Well, thank you, Michael, and thank you, Dr. Srikandi, for the honor of addressing this audience and for your very generous introduction. I'm sure my wife would be astonished to hear me treated as a celebrity. And thank you all for coming out so early in the morning, particularly for this subject that must be emotionally difficult for many of you. I know that you as human beings very likely know someone who has an issue with alcohol or drugs. Most people do. But I also know from studies that have been done of this topic that most treatment professionals don't like alcoholics and hate like hell treating them. On studies of who's your favorite kind of patient, psychiatrists routinely say our least favorite kind of patients to treat is an alcoholic. And that's true throughout the medical profession generally, at least it was at the time of these studies a few years ago, and there's no reason to think that it's changed dramatically. We also know from studies that most physicians have little or no training in addiction medicine. Let me ask, how many of you had at least one semester of addiction medicine in medical school? One hand goes up. I rest my case. And it's also true from studies that physicians routinely overlook alcoholism even when it's staring them in the face. If a patient can come into an office and present with a flag of breath that would knock over a horse, and the physician doesn't note anything in the chart about alcohol consumption. This is particularly true in the emergency room, where people come in with totally knocked out, and there's nothing in the charts about it. That may have economic reasons as well, but it's part of a larger picture in which physicians, in many cases, don't see alcoholism or other addiction. And as a result, many physicians are played like dopes by skilled patients who go to the Merck manual and look for a drug that they want, and then they memorize the symptoms for which this drug is prescribed, present with those symptoms, and get the doctor to prescribe them the addictive drug of their choice, and go to the next and repeat. And many doctors are played like that by expert patients, by expert addicted patients. And it's also a sad truth that healthcare professionals who specialize in treating the addictions are often treated as second-class citizens by their professional peers. This is true among physicians and apparently also among nurses and all up and down the scale, that those who know addicts and treat addicts by preference aren't accorded the same professional status. So those are some very sad things, and those are some points that I think cause emotional conflict for many of you, because as I say, as human beings, you know people who are addicted, but as professionals, you probably don't like them, or at least many people don't. So I'm here to try to talk about that and try to see if something can be done in the short time that I have here to explain why this is the case and perhaps point the way toward a solution. And the solution in a short comes from my title, that is to say, we need a genuinely medical model of addiction and of the addicted person. Now this may astonish you because you may assume that since the AMA, and I understand the Canadian equivalent as well, have since the 1970s declared alcoholism to be a disease, that therefore there must have been, at least at the time, a comprehensive medically and scientifically founded theory or model of what the disease of alcoholism consists of. Well, and if you go to a meeting of Alcoholics Anonymous, for example, you will find there inscribed as one of the foundational principles, alcoholism is a disease. So you might think that Alcoholics Anonymous had pioneered a disease concept with which you as medical professionals would be A, familiar, and B, comfortable. Neither of those is the case. I am trained in history of ideas, and so I did a little history of ideas research on this. And I can tell you that neither Alcoholics Anonymous nor the medical profession lies at the origin of the current disease concept that most of us carry around in our heads. The real origin of the disease concept that most of us carry around in our heads is with the alcohol industry of the United States. And it goes back to the 1930s. As you all know, there was 18 years of prohibition in the United States, during which the alcohol industry was basically outlawed. They were very close to the status that heroin dealers are in today. But they emerged from that in 1933, just 2 years before the founding of Alcoholics Anonymous, incidentally. They emerged from that in 1933 and were determined to remake their image. Their image had been based on the public perception, very widespread, even among those who opposed prohibition, that alcohol was corrosive of moral values, destructive of family relationships, ruinous to the economy. In short, alcohol is demon rum. Their product had been stigmatized in the popular mind with that label, demon rum. And so they were determined to change the image of alcohol, to make alcohol, to strip the demonic character of alcohol and to make alcohol acceptable. But they weren't so dumb as to think that you could just do away or ignore all the harmful consequences that are associated with alcohol use, drunkenness, and so on and so forth. So what they did instead of trying to gloss over that, is they sought to shift the blame for the harmful social consequences away from the product and toward the person who was drinking the product. And so from the mid-30s on, late 30s on, they sponsored, they paid money, they issued grants to the leading research organizations of their day to shift the focus of their research from the evils of alcohol to the discovery and development of a disease they called alcoholism. Now, at that time, that term had been invented, but it was not in widespread use. And there were very, very few people who would tell you that alcoholism was the name of a disease. It was the purpose of the image makeover campaign of the alcohol industry to create a disease called alcoholism and to fill it with content so that people would recognize it and study it. And toward that end, they founded the Yale they funded and founded the Yale Institute for Alcoholism. They funded a journal called the Yale Journal of Alcohol Studies, and they founded a group called Yale Summer Schools, which is a cadre training school for activists in the field, and sought by these means to create a public consciousness that there was a disease called alcoholism, and that the people who had negative consequences from alcohol had that disease, and they had negative consequences because they had that disease. The medical historian, I have to sit, you can read this all in my book, and I don't have the, Peter Conrad, sorry, yes, the medical historian Peter Conrad, who studied the history of this, says that in a nutshell, the purpose of the campaign was to shift the blame from the bottle to the man. The problems of alcohol do not lie in the product. The problems of alcohol lie in the man who drinks it, or in the person who drinks it. And that was the purpose of establishing the disease of alcoholism, to say that people who had trouble with alcohol were sick. Now, I mentioned the Yale Summer Schools, and out of the Yale Summer Schools came a particularly bright and brilliant student named Marty Mann, a woman who was a public relations specialist, extremely charming and attractive and witty. She had gotten clean and sober in Alcoholics Anonymous, and she made it her mission in life to popularize the concept of alcoholism as a disease. She crisscrossed the country, giving more than 4,800 speeches over a period of 15 years, whose keynote was, "Alcoholism is a disease and the alcoholic can be helped." Her organization, the NCEA, National Council for Education on Alcoholism, was funded by the alcohol industry. The alcohol industry provided the startup capital for that organization. Later on they withdrew, as they do, but the startup capital to get that rolling came from the alcohol industry. There was another source of support for the disease idea as well, and that was the emerging industry of alcoholism treatment providers. Now, these weren't medical people. These were people who operated treatment clinics, drying out clinics, mostly in the private sector. And for them, the important issue was payment. So long as alcoholism was considered just an illness or a malady, in other words, a metaphorical disease, but not a medically classified real disease, they couldn't get paid. They couldn't get insurance payment, they couldn't get government payment. And so for them it became a high priority to have alcoholism recognized and declared as a real disease, capital D, so that existing insurance contracts and government payments would flow to those who treated the disease of alcoholism. And so there was a tremendous movement set in place, partly with alcoholism, with alcohol industry money. I almost said alcoholism industry, and I wouldn't be too far off, but with alcohol industry money and with alcoholism treatment money, and with the leadership of the NCEA and its brilliant and charming spokesperson, Marty Mann, to mobilize a social movement throughout the United States to get Congress and the AMA to declare alcoholism a disease. That went on through the late 50s and 60s, and it engaged practically everyone in AA and associated organizations such as Al-Anon and NA and anybody related with it at all to lobby their representatives and their physicians and their health organizations to have alcoholism declared a disease. That concept was very successful. As you may know, if you've ever participated in this process, and I've talked to people who have, the AMA, the American Medical Association's process for declaring things diseases or undeclaring them diseases is not primarily a research process. It's primarily a political process. They get lobbied, they get pressured, letters get written, connections are made, phone calls are made. Shouldn't we take this off the list or put it on the list? An example is homosexuality. During much of the 70s and 80s, homosexuality was considered a disease, and then there was a huge campaign by elements of the gay community to have it taken off the disease list, and eventually that proved successful, and so homosexuality is no longer a disease. Alcoholism was not a disease. There was a huge campaign to have it declared a disease, and it became a disease. But as far as the medical research that's concerned, behind all of that, there really was very, very little. Dr. Thibault, Harry Thibault, the leading psychiatrist advising, a leader of AA, not a member of AA, but an intellectual leader of AA, wrote in a private letter in 1955, he says, "I cannot help but feel that the whole field of alcoholism is way out on a limb which any minute will crack and drop us all in a frightful mess. To change the metaphor, we have stuck our necks out, and not one of us knows if he'll be stepped on individually or collectively. I sometimes tremble to think how very little we have to back up our claims. We're all skating on pretty thin ice." He was talking about the scientific basis behind the claim that alcoholism was a disease. Now, probably, and Peter Conrad, the social historian who I've talked about before, observed also that there were hardly any physicians in the drive to declare alcoholism a disease. The medical profession was virtually absent, even though the governing board of the medical profession was declaring alcoholism a disease. The medical profession per se was practically absent from this drive. And to this day, many physicians do not believe that alcoholism is a disease and are resistant to the concept. But in those days, the situation that the science was in is probably best summarized by Dr. Enoch Gordis, Gordis, who was then head of the National Institute on Alcohol Abuse and Alcoholism, NIAAA, who said in 1987, he said, "In the case of alcoholism, our whole treatment system, with its innumerable therapies, armies of therapists, large and expensive programs, endless conferences, innovation and public relations activities, is founded on hunch, not on evidence, and not on science." He said the reason is that the central concepts of alcoholism were developed outside the mainstream of medical science and were influenced rather by religion, moral attitudes, psychoanalytic theories, and pop psychology. Let's take a little closer look at the basic concepts of alcoholism as a disease that you will hear. There are three pillars of what passes for a disease concept in most of the alcoholism treatment industry today, and that most of us carry around in our head. Number one, that alcoholism is, among other things, a spiritual disease, which can only be cured by a spiritual enlightenment involving surrender to a higher power. Number two, that individuals become alcoholic because of their moral shortcomings or their character flaws or other serious defects of personality. And number three, that alcoholics cannot help it because of their genetic constitution. In other words, if you look at an alcoholic patient through this lens, what you're looking at is an arrogant sinner who's deeply damaged in their psychological and moral structure and is genetically programmed for disaster. That's what this theory says. You know, it's a spiritual disease, so you're an arrogant sinner. It's a character flaw, so you're just really a rotten person. And number three, it's genetic, you can't help it, you poor dope, you're programmed for it. Not one of these pillars of the so-called disease concept that most people are working with has stood the test of the last 50, 60 years of scientific research. Spiritual disease. Well, countless laboratory animals have been teaching us that the development of alcoholism and other addictive diseases has much more to do with pharmacology than it does with theology. You can take a rat, and millions of rats and mice and other mammals are routinely turned into addicts in laboratories, maybe even right here in Victoria, turned into addicts simply by saturating their bloodstreams with a non-lethal but high dose of alcohol or other addictive drugs for a relatively short period of time. At the beginning of the process, the animal ignores alcohol, shows no interest in it, prefers the natural foods that are available. After 2 weeks of saturation with the bloodstream, the animal is completely turned around, ignores its natural foods, goes for the alcohol or other addictive drug, and if deprived of that, will press a lever thousands of times, tens of thousands of times, will ignore hot, cold, electric shock, water, sex, any other drive in order to get more of the addictive substance. They're turned into addicts, and laboratory experimenters do this routinely because the animals are such a good model of human addiction. Well, that's true. And if that's true, then what possible relevance could the concept of spiritual disease have to the development of the addiction? Spiritual disease is not a meaningful concept when applied to rats and mice, is it? Or fruit flies, or nematodes, all of which can be converted into addicts by the same simple expedient. What these experiments teach is that the roots of addiction lie in the direction of pharmacology and not in the direction of theology. Number two, personality defects. In the last 50 years, we have developed excellent tools, excellent instruments for measuring personality traits, such as the Minnesota Multiphasic Personality Inventory and a number of others. It is now possible to determine what people's personality traits are and then to see whether certain personality traits predispose someone to become an addict. To test theories such as whether maternal deprivation or authoritarian fatherhood or any of these other things that are thought to predispose people to alcoholism actually do. These studies over the past 50 years have come up consistently blank, negative. Every personality type, every personality defect or positive trait is about equally likely to become alcoholic or addicted if they start using addictive substances. There simply is no scientific truth to the concept of moral weaknesses, ethical defects, character defects, personality traits, and so forth as being involved in the etiology of alcoholism or other addictions. Finally, the belief that alcoholics are genetically programmed. If you will read the current issue of Scientific American, you will see bursting to the surface of a semi-popular magazine like that a dispute that has been raging in the field of genetics for the last 5 years or so. As you know, a little over 12 years ago or so, we first succeeded in sequencing the human genome. And we now have tools, unlike any that we've ever had before, for looking in the human genome to see where the genes are that might cause certain diseases. And so this research has been done for a broad range of diseases, including, of course, alcoholism and autism and cancer and heart diseases and many others. And the expectations and promises made at the beginning of the genetic research, the modern genetic research, was that we would soon locate the specific genes or gene variations or alleles that cause these specific diseases. If you will read the current summaries of what's happened with genetic research, you will see a tremendous earthquake through the science because what's been found in so many cases of major diseases is, in a word, nothing. The better we see into the genome, the more clearly we understand what's really happening, the fewer genetic roots we find of the major diseases. And that's the case as well with alcoholism. The idea that there is a gene, an alcoholism gene, has now been debunked. It is no longer the case that there is an alcoholism gene. We now can look in the genome. There is no such gene. There may be a number of genes that predispose people to alcoholism when in combination, but no one yet knows whether that's 8 genes or 100 genes or 800 genes that make up the pattern. And also we now know that there's not one single pattern, but there may be many different patterns. And we also know that each of these patterns is profoundly influenced by the interaction of the organism with the environment. The old idea of the DNA as a mainspring or as a computer program that determines the person's life and behavior has been completely exploded. If you read, as I say, if you'll read the Scientific American article, which summarizes much professional literature prior to that time, you'll see that the field of genetics research is in a huge crisis because of the fact that now that we can really see what's going on, we see that it's not going on, that our old preconceptions about many of these diseases are simply not true. So it's a great turning, it's a great exciting moment to be in genetics research because we now know the level of ignorance. But in any event, I want to stick to my subject, which is that the idea that there is an alcoholism gene and that the alcoholic is determined by his gene to become an alcoholic is just a myth. It's vaporware. It did not bear out. Bottom line, the religious, psychomoralistic, geneticist stock that the legacy disease concept conveys to us is without a scientific foundation. It is not a true, a genuine, and evidence-based model of addictive disease. Given the pejorative content that's inherent in this model, namely that the alcoholic client is an arrogant sinner with terrible character flaws who's genetically programmed, it isn't a surprise, is it, that physicians and other healthcare providers who have never taken an addiction medicine course to learn differently would have this furniture in their minds and that they would look at the alcoholic patient as someone that's not very pleasant to deal with, as someone that really ought to be somewhere else. Get out of here, go to AA, and don't bother me. That's too often the feeling you get. And the reason for it is that medical professionals haven't been supplied with a valid, empirically supported model of addictive disease. Now, as a result of the shaky, to say it in the most kind way, as a result of the shaky foundations of the legacy disease concept, the disease concept has many opponents. Not only popular opponents, but also scientific opponents. There was a book a few years ago by Herbert Fingerette attacking the whole disease concept and saying it was just all bunk, that there was nothing to the disease concept of alcoholism at all. And there are many purveyors, many disciples of that attack today. If you follow the popular literature, you will see any number of websites that tell you that the idea of alcoholism as disease is just junk. The Supreme Court of the United States, when confronted with the disease concept, when asked to test its validity in particular cases, has thrown it out with scathing and sarcastic remarks that the disease concept is amorphous, ill-defined, meaningless, empty of content, and certainly not anything that the court could base its decisions on. So you have a an opposition to the disease concept that would throw it out in its entirety. And the result of that would be, that if you discard the disease concept, what you're saying is that physicians should have nothing to do with it. It shouldn't even come to physicians' offices. To be sure, secondary symptoms of it, like the liver diseases and so forth, that remains for the doctors. But alcoholism per se, as a primary disease, is not for the doctors. It's not a disease. Get it out of here. And that means that that the jurisdiction over the alcoholic goes away from the medical profession and goes toward the clergy. The sinner, yes, the alcoholic is a sinner, so it goes to the clergy and to faith-based organizations, and it goes to the courts, the judges, and it goes to the prisons, where they punish or try to reform, or in any case warehouse, at least in the U.S., they warehouse and store the alcoholic until the money runs out. So the decision over whether alcoholism is a disease or not is not just a scientific decision. It is, in some ways, above all, a jurisdictional decision, an economic decision, and a social decision of great importance. It has to do with who is in charge of the person who has this disorder, who gets to work with them, and in some ways also who gets the money that's to be had, if any, in treating these people. So there's economic interests as well as legal and medical interests at stake in this, and has been for the past 200 years or so. There's a very excellent book, if you'd like to go deeper into this, by William L. White called Slaying the Dragon, The History of Addiction and Recovery in the United States for the past 250 years, 300 years, in which the struggle between the disease model and the penal model is detailed at great length and in great graphic detail, and is still with us today. Now, there are those who would throw the disease model out altogether, as I've said. I myself am not a party to that. I do not believe in throwing out the disease model. I believe that the cure to the defects of this legacy disease model is not in throwing out medicine, but in applying more medicine, real medicine, to the study of the alcoholic. The cure is not to throw the baby out with the bathwater, but the cure is to look more deeply into what happens with alcoholism and try to come up with a genuine medical model of the disease. Now, there's been a lot of research in the last 50 years, not only that debunks the old legacy model, but that works toward a positive understanding of what alcoholism and other addictions is about. And I'm not going to try to summarize this. I'm not going to go into any detail on this. There are very excellent books on it that you can look at. I just want to hit for you the high points. Number one, we now know that the addictive substances enter the brain, and that in the brain they connect with brain circuits that are already there. As you may know, scientists have discovered in the brain that there are native opioids, native cannabinoids, and so forth, that there are native inborn versions of the addictive substances that evolution has implanted or developed in our brains. And what the addictive substances do is to connect with those circuits and supercharge those circuits, by which I mean is that the potency of the external drugs that are put into the brain is vastly higher, exponentially higher than the potency of the indigenous drugs that our brain has naturally. So what the addictive drugs do is to latch onto brain circuits that we already have and overwhelm them in strength, and to create new brain circuits, what the neuroscientists call to create in the whole brain a neuroadaptation. That is to say, they literally reshape the brain circuits to match their ingestion and their repeated ingestion. And now, what happens then with the ingestion of these addictogenic substances is that the brain actually becomes rewired in ways that scientists are working very hard to understand in detail, but certainly can understand in terms of the aggregate influence that it has on brain physiology and behavior as well. Many people now understand this when it comes to nicotine, cigarettes, and when it comes to heroin and methamphetamine and cocaine. People are now willing to understand, even the popular mind now understands that these are addictogenic substances, that they rewire the brain. They don't just damage the brain, they rewire the brain to create new patterns of thought and behavior. But people have a kind of a blind spot when it comes to alcohol. People assume that somehow alcohol is different. We have an alcohol exceptionalism going on. There is no scientific basis for alcohol exceptionalism. Ethanol is the addictive ingredient in alcoholic drinks in the same way that nicotine is the addictive ingredient in cigarettes and other tobacco products. And so from the scientific point of view, alcohol is one of the groups of addictogenic substances. It is in that group, along with heroin and nicotine, and there is no there's no validity to an aggregate distinction that sets alcohol apart in a separate island. It isn't. Now, medical science needs to know a lot more about the specific molecular details by which the addictive substances reprogram the brain. We don't, for example, yet have a way of objectively testing whether addiction takes place. We can have a patient pee in a cup, we can tell what substances they have in their body, but we can't have them pee in a cup and tell whether they have an addiction. In other words, we can tell whether they have alcohol, we can't tell whether they have alcoholism. So the diagnosis of addiction still has to be made by a counselor or other clinician by looking at a rather loose 7-point scale of the DSM-4, the Diagnostic and Statistical Manual. And so it's still a judgment call rather than an objective bioassay. And that's a problem because that holds up the development of pharmacology for the addictions. We now have some drugs that are pharmacological interventions for some of the addictions. We have, for example, of course we've had methadone for some time. We now have buprenorphine for opiate addiction. For nicotine addiction, there are results with Chantix, although it has to be used with great caution because of possible side effects. There are some promising interventions for alcoholism with naltrexone, and there are other drugs as well. And these are in development and bear watching, and those of you who are medically concerned with addiction patients will know about those or will want to know about those. So what we need to know much more, what we already do know is enough for the foundations of a genuine medical concept of addictive disease. A medical concept based on the knowledge that addictive disease is caused by the ingestion of addictogenic substances, including, of course, alcohol. Once you understand that the addictive disease is caused by the addictogenic substances, then you can relieve the patient of the freight of moral, religious, psychogenic, and other judgments, pejorative judgments, that the legacy disease concept freights our heads with. You can forget about, you can put out of your mind the idea that the patient you're looking at is an arrogant sinner with character defects who's genetically programmed. That's junk. The problem is that the person has put addictogenic substances into their body, and those substances have rewired their brain to produce the behavior patterns and chemical patterns that make up addictive disease. Once you understand that, you also understand that the important thing is to tell them to stop. It's similar to a case of poisoning. If someone has arsenic poisoning, well, the obvious first step is what? Stop putting arsenic into your body. Hey, duh. And it's also, and this involves a further step in patient treatment that I think some doctors are ready to take and some maybe aren't so ready to take. In the case of smoking, my experience has been that most physicians now screen for smoking. They ask the patient, do you smoke? And if the patient says, yes, I smoke, the doctor says something like, well, consider stopping, or stop, or don't do it anymore. And it's very short, and it's very cut and dried, but it's prevalent. Everyone does it. It's time to start doing that with alcohol, folks. Find out, don't ignore it, find out whether your patient drinks. And if their drinking is at all more than minimal, begin to advise them, hey, consider stopping. Or if the indications are stop, make that part of your routine medical practice. That's a suggestion that will save many lives. There have been studies of the effect of a simple doctor's advice on a patient. Those are called in the literature brief interventions, as opposed to the orchestrated mammoth symphony orchestra interventions where you get all their friends and family together and tell them, you're an alcoholic, and you need to go into treatment. Not that. No. We're talking about brief interventions where a doctor or a nurse or a dentist says, you need to stop drinking. And that brief intervention is often as effective as months of expensive treatment in getting the patient to stop. You need to use that opportunity. You can save many lives. Another change that needs to happen, if I may so suggest, is in referral practice. If you look at the patient as a spiritually and morally damaged person, then your first instinct, almost like a knee-jerk reaction, is go out and go to AA. Well, AA is a fine organization that is very effective, but for a very small percentage of the people who go there. Reliable studies based on AA's own membership surveys show that out of 100 people who start AA, at the end of 1 year, only 5 are left. Only 5 are left, a 95% dropout rate. We got to do better than that, folks. We've got to do better than that. So I would ask those of you who do referral to please inform yourself about the available alternatives for support groups for your alcoholic and addicted patients. Find out what other groups are available. Right here in the Victoria, you have 5 other groups, and soon there will be 7, and probably next year you'll have twice as many of the LifeRing groups that use a slightly different approach to alcoholism, and it may be a better fit for some of your patients. You may save lives, you may help recoveries by broadening the scope of your referral practice and giving your patients a choice. And imbue your patients, if you would, if I may plead with you, imbue your patients with the confidence and a sense of purpose in knowing that addiction can be beaten. Don't imbue them with a sense of helplessness. Don't beat them up. Don't tell them they'll never lick this, that they're powerless and so forth. No, tell them that they can do it, and let them know that even if treatment doesn't work for them, that the majority of people, the majority of alcoholics who get clean and sober do it with community support or with family support without organized medical assistance, so that even if support groups don't work for them, even if treatment doesn't work for them, don't give up. You can still get clean and sober, and most people who get clean and sober do it on their own. So imbue your patients, if you would please, with the knowledge that it's possible to get clean and sober, that they have the power within them to do that, and so give them confidence and give them hope as they leave out of your office that they can do this. Well, my time is up. I have said a great deal more about this subject in the book that Michael held up, Empowering Your Sober Self. Chapter 6 deals exclusively with the topic of my talk here. And the main message that I want to leave with you is a message of hope. That is, even though the old furniture in our minds for dealing with addictive disease is a furniture that deserves to be sent to the Goodwill, it's not solid, that there is a great amount of research that has been done, a great amount of scientific knowledge that is now available, and that the foundations of a genuine medical model for treating addictive patients do exist, and that if you will inform yourself, if you will grasp that, you will find, I think, a tremendous improvement not only in the medical profession's attitude toward addicted persons, but also in your effectiveness in dealing with addicted persons and helping them return to wellness. Thank you very much.
Any questions?
Yeah, I'd like to, is it Doctor?
Martin.
Martin? What do you think of the link between codependency and alcoholism and the other addictions?
It's a tremendously important topic. As we know, alcoholism is a, quote, family disease, and very often the alcoholic sustains their symptoms in a family context or in a friendship context. And so often the members of the family who are involved with the alcoholic are powerfully ambivalent, as is the alcoholic themselves. Powerfully ambivalent, on the one hand wanting the person to stop, on the other hand taking concrete steps to protect the alcoholic, to help the alcoholic, to sustain the alcoholic in the disease, because it gives them control over the person in a way that they would not have control if the person had achieved wellness. So that's a tremendously important topic, and one where I think the medical profession has not got very far and may not get very far, because a codependent person doesn't have any symptoms that are medically cognizable. So we're dealing, I think that's within the subject of counseling, the psychologist, perhaps clergy as well. All the helping professions, short of the ones that write prescriptions, will have to get involved in that.
Yeah, I guess I'd like to make a comment that I appreciate the journey that people who work with the addicted patients have gone through, and they're really moving towards having some answers. And what you're talking about indicates that, and other medications that have come forward have indicated that. So now, for instance, here we have mental health and addictions. But the comments you made about the journey really applies to a lot of other things that I'm a physician, that we physicians, and I think as a human being, we struggle with. We do not like things that we cannot fix or address.
Yes.
And we tend to stigmatize and blame the patient for things that we don't know how to treat.
Right.
And so we struggle with, and alcohol is ahead of us, with the brain injury population, for instance, or with a personality disordered population.
Yeah.
And we tend to stigmatize them and say they're not our territory or not on our watch kind of thing. Simply, I think, because we don't have a pill. Give us a pill.
Yes.
We have a pill or something that can cure the personality disorders. They're going to be top on the list, and we're going to work with them.
Yes. Yes.
So I just wanted to make that case for the other stigmatized areas that we struggle with.
Yes.
And you mentioned psychoanalytic psychotherapy, which I have a soft spot for, because it involves understanding the patient and really trying to understand all the forces that you're mentioning to get to a deeper understanding of the person. In the old days, and I keep saying this, I'm quite old, and I remember when we didn't have the medication.
Yes.
And we struggled and came up with silly answers sometimes, but we really struggled to try to understand the patient.
Yes.
And when drugs came on, the psychotherapy was rejected, and now the promise of drugs has its limitations too. So we're going to psychotherapies that have quicker fixes and trying to help patients. But I would say that that's a piece that shouldn't be divided and should be really incorporated into the total holistic kind of care of a patient. Phew, sorry, Satish, long speech, but I've been waiting to say something like that.
Thank you very much. Thank you so much.
First of all, Mark, thank you very much for coming. I appreciate it.
My pleasure. Thank you for having me.
I was very interested in the disease aspect of it and the controversy. Homosexuality was a disease. That must have been before my time. I'm not that old, I hope. How long before alcoholism do you think they'll declassify that as?
I have no idea. Of course, my crystal ball is in the shop, but I don't think it's going to be declassified. I think what's happening is that the disease concept, which was initially filled with junk, is gradually going to be filled with solid stuff, and that we're moving visibly toward a medically valid concept of addiction, and I think that's going to continue. And as a result, I think the disease concept is going to have much more validity 10 years from now than it did when it was launched. That's at least my guess as to what's going to happen. Best I can do. Of addiction counselors. And the most common complaint of all is that we try to send our patients to these groups and they come back and say, this is not my cup of tea, don't you have anything else? And so we've been struggling to build additional roads and to build additional groups, and the healthcare professionals can be very, very helpful. by referring patients to these groups and by providing resources such as room assignments to make them available to the alternative groups. The LifeRing groups are for all ages. The average age, we did a survey about 5 years ago, the average age is high 40s, and certainly people who are seniors are quite welcome. It's not a problem. So if you send someone, who's a senior to a LifeRing group, they wouldn't have any problem at all. Probably would not be the oldest person there even, So people are certainly welcome. Referrals are a very, very big issue for support groups. Some healthcare providers take the attitude, well, you only have 5 meetings, and so we can't refer to you. We won't refer to you until you have 500 meetings, for example. But the problem is that until healthcare providers start referring people to these groups, there'll only be 5 meetings. Healthcare providers aren't passive in this. Healthcare providers are also producers of meetings, in the sense that if you refer to people to the meetings will come and flourish. So part of my mission here today is by trying to outline for you what a valid medical model of addictive disease looks like, is to encourage you to look at the addicted patient as a person who is capable of self-help, as a person who is not a sinner or morally deficient or genetically programmed, and therefore that it makes sense to send them to a group that recognizes their inherent healing powers, that doesn't look at them as powerless, and that will enlist them and mobilize them to develop a personal treatment program that works for them. In other words, a group that works by positive reinforcement. Positive reinforcement can only work if there's something positive in the person to begin with. If you look at the person as purely negative, as just slag, then positive reinforcement makes no sense. The only thing that makes sense is to beat them up. That's decidedly not what we do in LifeRing. We are a positive reinforcement group. We recognize the positive aspects, the strengths in a recovering person, and we bring about transformation by recognizing and reinforcing those strengths. Now, if you want to know more about that, there's a lecture I'm giving when?
Tonight, 7 o'clock, Mathematics and Social Sciences Building at UVic, room number 104. And that'll be a more expansive view of what LifeRing does, how the meetings work.
And it'll have slides, so bring a pillow.
Much of your discussion has to do with what is disease, how is disease defined?
Yes.
And one of your arguments was that alcoholism is not a disease because, as Jerome Wakefield says, there is no harmful dysfunction. He defines disease as that which has a harmful aspect to it and is a dysfunction of the natural system of the body. And that is one of the ways that you separate out homosexuality is not a disease because there isn't a dysfunction. The political prisoners in various countries don't have a disease because there is not a dysfunction of their natural system. If you then look at alcoholism and say that you can't genetically define people as being alcoholic, you can't genetically define people as being some other kind of thing, you end up deciding that there is no dysfunction of the natural system, therefore it is not a disease. But that kind of thinking doesn't really address the central issue, what is a disease? Because if that is what you use, then an infection is not a disease. There is nothing dysfunctional about the body system when it is invaded by HIV, by pneumonia, by the common cold. There is nothing of a disease aspect when the person is exposed to arsenic. The body functions as it can, but it has been overwhelmed by something that it can't handle. An alternate definition of what a disease is that which physicians treat. So if you kind of get down to it, it doesn't matter whether alcoholism is a disease or not.
Well, I think you've outlined both sides of a debate that's been going on for many decades about whether alcoholism is a disease. I may not have made myself very clear. I do believe alcoholism is a disease, but I believe that the definition of the disease is different from the legacy definition, which sees the alcoholic as, you know, a sinner with moral defects, genetically programmed to be a troublesome person. I do believe alcoholism is a disease, and that a medically viable concept of it has emerged and is filling out. The problem still remains that so far we have not discovered the biopharmacology. We have not discovered an objective manifestation that we can test for. We can't do a biopsy. We can't do a lab test to determine whether somebody is an alcoholic. We still are working with clinicians' judgments. And I don't know whether we ever will be able to have a bioassay for the disease. It may be that what the disease consists of is a particularly exponentially powerful, deeply engraved reinforcement loop in the brain. A brain circuit like any other brain circuit, the brain circuit that teaches us how to play a violin or how to throw a baseball and so forth, but because of the powerful reinforcing properties of the drugs, much more deeply etched or embedded or reinforced than any other brain circuit. And it may be very difficult to test for that. You know, you don't want to stick needles in the brain, and the MRIs and CAT scans and so forth may not be able to pick it up because it looks like an ordinary circuit. It may be that that's what we'll have to work with forever. But there's no reason why that kind of abnormal brain circuit, even though it's hard to detect in biopsy, is not a diseased element. There's no reason why that should not be declared a disease.
So perhaps the diathesis stress model would be a more effective way of looking at alcoholism or addiction or mental health issues.
May I answer that, Martin? See, one of the confusions that people have in their mind is because of DSM. DSM is not about diseases. DSM is about disorders. And disorders are a collection of symptoms. Anything that may cause problem in the society is a disorder. Disease, on the other hand, is something where you understand the pathology, and with treatment you are able to treat pathology. Now, everything that Marty has said will apply to schizophrenia as well, because you cannot have exact pathology of schizophrenia. We know some of the risk factors, we know some of the changes that occur in the brain, we think we understand the biochemistry, but can you say that you can diagnose schizophrenia 100% in laboratory? No, you cannot do that.
So
we are still struggling with the pathology.
It would be more appropriate then to say that alcoholism is a disorder,
The
but
problem
it is not a
is,
disease.
when you want to treat someone, when you want to relieve somebody's suffering, you have to have some basis to begin with. So you say, you give it a name, you try to treat it, and then you study it. But Marty probably says that you call that a disease. Do you have genetics? No. Do you have biochemistry? No. Do you have physiology? No. We know the consequences. But somewhere medicine has to begin by giving it a name. And it is possible that maybe 200 years down the road, we'll say alcoholism is not a disease. It is not even a disorder. In fact, this is how exactly it was 200 years ago. Alcoholics were bad people. They were just social outcasts. In fact, that was not a disease. But this has happened through medicalization of society. And when you have socialized medicine, there are a number of conditions which are called diseases or disorders, but may not necessarily fit the medical criteria for a disease with pathology that we understand. Sorry, Marty.
Beautifully said. I couldn't have said it better.
I think we need to stop here. Thank you very much.
Thank you all very much. Thank you so much for that. It was very important.